Good day, viewers. This is Dr. BK for you with a new topic on the upper limb, and today we are going to discuss about the front of the forearm. So, here our objectives of today's topic will be to understand the location and names of the muscles of the front of the forearm, the course of major arteries and nerves which are present in the forearm, and their applied anatomy. Okay. Now coming to the forearm, you are able to see the forearm is the area which is present from the elbow joint up to the wrist joint. Okay, and it mainly contains the radius bone, which is the lateral bone of the forearm, followed by the ulnar bone. So this is the radius bone and that is the ulnar bone, which is medial, and both are actually connected by the interosseous membrane. Okay, so the two bones connected by the interosseous membrane also forms the middle radio-ulnar joint. Now let us quickly review the osteology of the radius and ulnar. So the radius of ulnar consists of the head of the radius, followed by this constriction, which is actually called as the neck of the radius. Then you have the tuberosity, which is the radial tuberosity. Okay, so that is about the radial tuberosity. Then this is actually the shaft of the radius. Okay, so that is the shaft of the radius. The shaft has consist of, mainly you are able to see, that is the medial border where the interosseous membrane is attached. Then you have the lateral border. The shaft in the middle also shows a maximum convexity. Starting from the lower border of radial tuberosity, what you see here is the anterior border, which is somewhat curved, and lower part it is not very conspicuous. When you look at the lower part of the radius, it is expanded rather than the upper part, more expanded and massive. And laterally you see an extension, which is actually the styloid process. The inferior surface actually takes part in the articulation with the wrist joint. And here you have a notch for the head of the ulnar. Okay, so on the medial surface of the radius, you have a notch which is actually called as the ulnar notch for the articulation of the head of the ulnar. Now coming to the ulnar bone, in front, this process which is projecting, which is called as the coronoid process. This is also called as the tuberosity of ulnar. Then backside, which is hidden from your view, is the olecranon process. Both the process forms a U-shaped notch, which is called as the trochlear notch, where the trochlea of the humerus is going to articulate. Then on the medial side of the upper part of the ulna, you have a notch for the head of the radius, which is actually called as the radial notch. So that is actually called as the radial notch. Then you have the shaft. This is the medial border of the shaft. Then you have the lateral border of the shaft, to which the interosseous membrane is attached. Then you have the anterior border. When you look at the lower part is very small as compared to the upper part, and this is actually called as the head of the ulna. Then you have a small projection more medially, that is actually the styloid process of ulna. Okay, so now going directly to the soft tissues of the forearm, again you have the deep fascia covering the muscles, which is deep to the superficial fascia, and it's called as the antebrachial fascia. So this is nothing but the continuation of the brachial fascia or the deep fascia of the arm. This fascia, what happens after surrounding the muscles, it is also going to form septa, thereby the forearm is going to get compartmentalized into the flexor compartment and the extensor compartment. So the two compartments are there. The flexor compartment is the anterior compartment, and then you have the extensor or the posterior compartment. The deep fascia shows some modifications in the lower part of the forearm near the wrist, that is in the flexor region. It forms a retinacula, the flexor retinaculum, and in the extensor compartment it forms the extensor retinaculum. It is a band of fibers which is present in the front and back of the wrist. Okay. So when you look at the muscles, more massive, the flexor muscles. So today's class is on flexor compartment. We are going to mainly deal with the flexor compartment because they act against the gravity, anti-gravity muscles. Okay. So when you want to flex your arm, naturally when you want to flex your forearm, so you bend your forearm forward, which is against the gravity. Okay. And these muscles, the muscles of the forearm are mainly going to act on your wrist and on your digits. So naturally flexion of wrist or digits is again an anti-gravity action. So that is why these muscles are bulkier as compared to the extensor muscles. Radial and ulnar artery is present, and mainly the nerve of the anterior or flexor compartment is the median nerve and the ulnar nerve. So always remember, all the flexor muscles are supplied by the median nerve, except the medial 1.5 muscle is supplied by the ulnar nerve. So that medial 1.5 muscle is the flexor digitorum profundus, medial half, and flexor carpi ulnaris. So now coming to the muscles in the anterior compartment of the forearm or the flexor compartment, here we will be referring it as the flexor compartment. They are actually arranged in 3 groups. The superficial group, the muscles of the superficial group are here. Actually the superficial muscles are not shown here, only you see the intermediate muscle, Pronator Teres. So the superficial muscle Pronator Teres, which is actually cut for you. Then flexor carpi radialis. Okay, flexor carpi radialis. Flexor carpi ulnaris, you are able to see here. Flexor carpi ulnaris, Pronator Teres. Flexor carpi radialis. Then one small muscle with a very tiny belly and a long tendon, which is absent most of the time, that is actually called as the palmaris longus. So the palmaris longus may be absent, and if at all it is present, it will form a very tiny belly and a long tendon. The tendon, what happens, will pass on front or top of this, I told you, no, flexor retinaculum fibers, modification of deep fascia. The palmaris longus will pass on top of this flexor retinaculum, and the tendon will get flattened to form an aponeurosis, which is called as the palmar aponeurosis. So with respect to palmar aponeurosis and flexor retinaculum, which is not under the purview of today's class, that we will be discussing in the part. So mainly 4 muscles, then one muscle is in the intermediate group, and that is the flexor digitorum superficialis. Here what you see is the flexor digitorum superficialis, a massive muscle with 2 heads, and it has 4 tendons for the medial 4 fingers, that is the 2nd, 3rd and 4th digit. In the deep group, 3 muscles are present. The first muscle you are able to see here is the flexor digitorum profundus. It is actually the flexor digitorum profundus. 4 tendons again for the flexor digitorum profundus for the medial 4 fingers. Okay, the medial 4 fingers, and see where they are getting inserted. They are getting inserted into the distal phalanx. So they are responsible for the flexion of the distal interphalangeal joint, distal phalanx. Whereas if you look at the tendon of the flexor digitorum superficialis, only one tendon is shown here. It actually splits and gets inserted into the shaft or sides of the middle phalanx. So thereby flexor digitorum superficialis is responsible for flexion at the proximal interphalangeal joint. So this is the proximal interphalangeal joint, and this is the distal interphalangeal joint. Both the muscles on prolonged contraction can also bring about flexion at the wrist. Okay, so these muscles are mainly passing deep to the flexor retinaculum. So deep muscles, I will again repeat, flexor digitorum profundus, flexor pollicis longus, a long tendon to the thumb, going and inserting into the distal phalanx. Going and inserting into the distal phalanx, responsible for the flexion of the thumb, flexor pollicis longus. More deeper plate, you see a quadrangular or a quadrilateral muscle that is actually called as the pronator quadratus. So three muscles in the deep, flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. And profundus is a hybrid muscle. So I have already told you now what is the meaning of a hybrid muscle, which means this muscle receives nerve supply from two sources. In this case, profundus receives nerve supply from the ulnar nerve as well as the median nerve. So here you are able to see the flexor muscles of the forearm, starting from medial to, you go to lateral, and this is a small gap which separates the flexor compartment from the extensor compartment. The extensor mainly two muscles, you can see the brachioradialis muscle and the extensor carpi radialis longus deep pivot, but mainly the brachioradialis muscle which is seen in the extensor compartment should not be mistaken and identified as flexor muscle. One way to identify is you are able to see this large bulk coming from the medial epicondyle. So this bulk is actually called as the common flexor origin. This is actually called as the common flexor origin, from where most of the flexor muscles of the forearm, muscles of the flexor compartment of the forearm, they originate. So the muscles you are able to see superficially, that is your Pronator Teres, which arises by two heads. So a humeral head, it has a humeral head and an ulnar head. Humeral head arises from the supracondylar ridge, that is above the medial condyle of the humerus. And it is going to get inserted into the most convex surface of the shaft of the radius. Between the two heads, what happens is the median nerve is going to pass between the two heads. The next muscle you see here is the flexor carpi radialis. So that is the flexor carpi radialis for you. The next lateral muscle, medial, because from medial to from lateral to medial we are doing. So next muscle will be the flexor carpi radialis muscle, which is going to get inserted. Origin from the common flexor origin, insertion into the first and second metacarpal bone. I told you a thin muscle, very little belly and long tendon is the flexor palmaris longus muscle. The palmaris longus muscle will pass in front of the palmar aponeurosis and it gets flattened to form the palmar aponeurosis, passes on top of the flexor retinaculum. Palmaris longus passes on top or superficial to flexor retinaculum, and it is going to form the palmar aponeurosis. Then what you see here is the flexor carpi ulnaris. Pronator teres, flexor carpi radialis, palmaris longus if present, then flexor carpi ulnaris. Flexor carpi radialis and flexor carpi ulnaris are involved in the flexion of the wrist. Okay. When flexor carpi radialis joins with extensor carpi radialis, it might also produce abduction. Flexor carpi ulnaris, when joined combined action with the extensor carpi ulnaris, will produce adduction of the wrist. The next group of muscles you see here, the intermediate group, what you see here is the flexor digitorum superficialis, one muscle alone, which has been reflected for you to show the deep group. Okay, that is the flexor digitorum profundus. It consists of 4 tendons. It is going to get inserted into the medial 4 fingers, into the distal phalanx, and you are able to see the median nerve, and that is the ulnar artery and the ulnar nerve. Okay, this is actually your radial artery. radial artery is somewhat deeper, whereas ulnar artery and ulnar nerve are superficial structures in the medial side of the forearm. Okay, and this part is going to be your cubital fossa, where you have the brachial artery divided into radial and ulnar artery, median nerve, tendon of biceps. The more deeper plane, what you see here is this muscle, pronator quadratus muscle, a quadrilangular muscle, I told you. That is the interosseous membrane. On top of the interosseous membrane, you see one artery and nerve, anterior interosseous nerve and anterior interosseous artery. Anterior interosseous nerve is nothing but the deep branch of median nerve. It is the deep branch of median nerve. Anterior interosseous artery is again a branch of common interosseous artery, which is from the ulnar artery. Common interosseous artery dividing into the anterior and posterior interosseous artery. Both are present on top of the interosseous membrane. Then they pass deep to the pronator quadratus and they pass to the extensor compartment, and they are going to take part in the anterior interosseous artery will take part in the dorsal carpal arch. Okay. So that is about the muscles. So there is you need not memorize the origin and insertion of all these muscles, and it is also not necessary at the undergraduate level. Only thing you should remember is certain muscles, as I told you, deltoid, biceps, these muscles, you should have a knowledge of the origin and insertion. Apart from this, collectively these muscles you can know. I told you from the common flexor origin they arise, and insertion I told you of the flexor digitorum superficialis and flexor digitorum profundus. What happens to the palmaris longus? Then this is pronator quadratus, which is stretching between the lower part of the shaft of radius and ulna. Okay, so you have a general idea about their origin and insertion, followed by their nerve supply is very important, and action, which I have listed for each and every muscle. Okay, they mainly act on the wrist, the muscles which are present in this flexor compartment of forearm, and also they act on the fingers, especially the flexor digitorum superficialis and flexor digitorum profundus. So this is the cross section of the forearm, where you are able to see the radius and the ulna. So naturally this should be the lateral part and this should be the medial part. And the interosseous membrane, these are the group of muscles. What you are able to see here, the flexor muscles medially oriented, they are not. See, look slightly, they are oriented, inclination towards the medial side. Superficial group of muscles, flexor carpi radialis, palmaris longus, intermediate flexor digitorum superficialis. Deep muscles, flexor pollicis longus and flexor digitorum profundus. This is the extensor group of muscles. They are also present in two groups. Superficial extensors you are able to see, especially the brachioradialis on the flexor compartment. So this should be your ulnar nerve and artery, and this should be your radial nerve and artery. Deep branch of median nerve is the anterior interosseous nerve, whereas the main median nerve is present between the superficial and deep flexors. Okay. So now when you look at the cross section, you have an idea of how these muscles are oriented, how the vessels are oriented. So again, this will give a fair idea when you write about the course of the arteries and nerves, and when you write about the course of these vessels, because again you need not memorize the course. So whenever an artery or a nerve is asked, what you should do is mainly first know its origin. In case of an artery, it is from which branch, then where it is going to terminate, then what are all the branches, name the branches. And what happens is, apart from naming the branches, what do they supply? So this is very important. Rather than memorizing, it passes between this muscle, comes out of that muscle, and all those course. General idea of course. Now for example here, when you see about the median nerve, I can tell it is present between the superficial and the deep muscles. Seeing this itself, I can tell it is present between the flexor digitorum superficialis Anteriorly and posteriorly it is related to flexor digitorum profundus and flexor pollicis longus. So like that you can describe. Now mainly you should write again of the root value, especially for the limbs, and then what happens, how it terminates and its branches and its nerves supply, what are the structures it supplies, whether it is going to supply any muscle, whether it is going to supply any joint, that is more important rather than describing the course. So why I am telling this is because students find difficulty in anatomy mainly when they want to memorize all these course. It passes through this muscle, it comes out of this muscle, it winds around. I am not telling that it is not good to memorize, but if you are aiming for more than 80% distinction, then okay. Otherwise, what happens is instead of completely omitting the topic or omitting that question in the university exam, if you write a general idea, that itself will score you 50 to 60% of marks. So the nerves present in this compartment is the median nerve and the ulnar nerve, and the artery is the radial artery and the ulnar artery. Okay, so that is going to be radial artery and ulnar artery with the median nerve here and the ulnar nerve. Radial nerve does not supply any structures in the flexor compartment. Veins superficially situated, that is the cephalic vein and the basilic vein. So now we are going to see the median nerve course in the forearm. So you all know the origin of the median nerve, C5, C6, C7, C8 and T1, because by the union of the medial root of median and lateral root of median. Okay. So it is also called as the nerve of front of forearm, and it is also called as the laborer's nerve. Why it is called as laborer's nerve? Because it supplies the most of the flexor muscles, and you all know that flexor muscles anti-gravity and more powerful action. Okay, so you know what are all the job or work a laborer does. For him, the flexor muscles is indispensable. So the nerve supplying the muscle is the median nerve. That is why it is actually called as the laborer's nerve. Okay, so that is the origin for you, as I have earlierly mentioned. C5, C6, C7, C8 and T1. Now, how it enters into the forearm? You all know that we have already discussed. The median nerve is the most medial structure in the cubital fossa. Okay, so from the cubital fossa, what happens is you can write the relations of the cubital fossa. It is present medial to the brachial artery. Then it enters the forearm between the two heads of the Pronator Teres. Here you are able to see it is entering between. This is the humeral head and superficial head are called as humeral head, and the deep head is the ulnar head. Between the two heads, the Pronator Teres, the median nerve is going to enter the forearm. Now, after passing between the two heads, it is present between the superficial and deep group of flexors. So, it is present between the superficial and deep group. Here you see the flexor digitorum superficialis, and behind you see the flexor digitorum profundus. Then, what happens is it descends vertically, and in the lower part of the forearm, it is somewhat, you are able to see here, it is present between the palmaris longus and flexor carpi radialis. So that is the flexor carpi radialis muscle for you, but palmaris longus muscle is not shown. So that means it is somewhat superficial in the lower part of the forearm or near to the wrist. Okay. Present between the superficialis and profundus, lower part of the wrist, present between the tendon of the flexor carpi radialis and palmaris longus. Then it is going to pass deep to the flexor retinaculum. Okay. So now the superficialis muscle has been removed, and you are able to see the course of the median nerve. So it is present between the superficialis and profundus tendon. The lower part of forearm, it comes near somewhat to the surface, and here it is present between the tendon of palmaris longus and flexor carpi radialis to pass deep to the flexor retinaculum of the wrist. What are the branches given by this nerve? Definitely it is supplying the muscles. So muscular branches, one to the pronator teres. It's given proximally, more proximal level before entering the muscle. Between these two heads of the muscle itself, it will supply this muscle. Then branches to flexor carpi radialis, palmaris longus, flexor digitorum superficialis. Okay. So in the upper part of the forearm, it supplies these three muscles: palmaris longus, flexor carpi radialis, and flexor digitorum superficialis. I already told you this muscle has got 4 tendons. Of this, the tendon to index finger is supplied by the median nerve at the middle of the forearm, the branch, okay, to the index finger. Now, why I am specifying all these things? At which level it is giving branch to which tendon? Because only then, if the nerve is damaged, you should know at which level the nerve is damaged, what are all the effects it will produce. Okay. Now, for example, in the middle of the forearm, if it is going, the nerve is going to get a cut or damaged, then naturally all these muscles nerve supply will not be disturbed. Only the nerve supply to the superficialis tendon of the index finger will get involved. Then articular branches to the elbow joint, superior inferior radial ulnar and wrist joint. Okay, so since the nerve passes through all these joints, definitely it will supply this joint, muscles around the joint, and also the skin on top of this joint. So here you are able to see the median nerve. The deep branch of the median nerve is called as the anterior interosseous nerve, because it is present on top of the interosseous membrane and closely related to the anterior interosseous artery. The nerve and artery are actually seen together. Okay, so it arises from the lower border of the pronator teres and supplies the deep muscles, mainly flexor digitorum profundus lateral half, that is the index and middle finger. Of the 4 tendons, the lateral 2 tendons it will supply. Then it will supply flexor pollicis longus, it is a flexor of the thumb. Then it is going to supply a quadrilateral muscle which is present here, called as the pronator quadratus. The pronator quadratus, flexor pollicis longus, and lateral half of the flexor digitorum profundus. The anterior interosseous nerve supplies the deep flexors. Then it is the anterior interosseous nerve which is going to supply your inferior radial ulnar and wrist joint. So that is the anterior interosseous nerve for you in front of the interosseous membrane. Pronator quadratus muscle you are able to see here. So along with the anterior interosseous artery, it is running and supplying your deep muscles, and it passes deep to the pronator quadratus, and it is going to supply your inferior radial ulnar and wrist joint. Now apart from that, supplying the muscles of the forearm, flexor muscles which is present in the forearm, it will give a palmar cutaneous branch which will supply the skin over the thenar eminence and the central region of the palm, this area. Skin over the thenar or ball of the thumb, and the central palmar region, that is the skin on the center of the palm. And sometimes it may communicate with the ulnar nerve, and that is called as the Martin-Gruber connection. What is Pronator Teres syndrome? That is, Pronator Teres syndrome is actually nerve entrapment neuropathy. When the nerve gets entrapped between the two heads of the pronator teres, then naturally all the muscles which is going to supply below that, especially the anterior interosseous nerve structures supplied by it, you will have weakness of muscles. So anterior interosseous nerve palsy because of Pronator Teres syndrome causes weakness of pinch grip. That is, you want to pinch with the elbow of your thumb and the index finger. Flexor pollicis longus is not working, so you cannot pinch between the two fingers. Suppose somebody tells take a pinch of salt. You use your finger, your thumb and the index finger. For this flexion of the flexor pollicis longus is necessary. Then flexor digitorum profundus lateral half is also involved. This is Pronator Teres. If there is a lesion above upper part of the elbow, we have loss of pronation and weakness of flexion of hand and wrist. So total function is lost. All the muscles supplied by the median nerve will get paralyzed. So you have weakness of flexion of hand and wrist. This might occur the supracondylar fractures. Okay. Pronator Teres syndrome is nerve entrapment neuropathy and it is not common. Only sometimes it might occur. And the other one is the carpal tunnel syndrome, where the median nerve is getting trapped inside the carpal tunnel. So this is the carpal tunnel. I will be speaking about in detail about the carpal tunnel in some other class. So it is a narrow osteofibrous tunnel which is between the flexor retinaculum and the proximal row of carpal bones, scaphoid, lunate, tricutral, you are able to see. Narrow passage for the passage of 4 tendons of superficialis, 4 tendons of flexor digitorum profundus, then palmar flexor pollicis longus in a separate compartment with its synovial sheath, and also you are able to see flexor carpi radialis. So with almost 4 plus 4, 8 and 9 tendons, which is almost crowded, and what happens is the median nerve also passes through that. So when there is a compression of that, the thenar muscles will get affected and you get a condition called as ape thumb deformity. But the skin over the thenar eminence or the central part of the palm will not get affected because palmar cutaneous branch which is given by this muscle, it's given by the median nerve, passes above the flexor retinaculum, and also because of the branch is given well above the nerve before entering the flexor retinaculum. Okay, so that is about the carpal tunnel. I again repeat you, the carpal tunnel we will be discussing in some other class. So that is the Pronator Teres syndrome, when the nerve is getting trapped between the two heads, between the Pronator Teres, two heads of the Pronator Teres, nerve entrapment neuropathy. Pain over the region, weakness of the flexion, especially the lateral 2 fingers, and flexor pollicis longus, anterior interosseous nerve mostly affected. When you try to pronate, ask the patient to pronate against resistance, provocative maneuver it is called as, he will feel the pain and tenderness over the region of the Pronator Teres. Next, coming to the next nerve, which is actually the ulnar nerve. It's also called as the nerve of the hand. When the median nerve is called as the nerve of the forearm, it is called as the nerve of the hand and also called as the musician's nerve, because it is going to supply almost most of the muscles of the hand, short intrinsic muscles. These short intrinsic muscles move your fingers. Very fine movements of the fingers are responsible. These muscles are responsible. So for a musician to play any musical instrument, especially the string instrument or it might be a wind instrument, naturally this nerve integrity is very much responsible. So that is why it is called as the musician's nerve. So for the medial cord of brachial plexus, root value C8, T1 and of course C7 is also contributed to some extent. That is why it is put inside the brackets. So in the arm, it lies first posterior to the brachial first part of the axillary artery, then it lies medial to the axillary and brachial artery. To some extent, briefly, it pierces the intermuscular septum and seen in the posterior compartment, the lower part of the arm especially, and passes behind the medial epicondyle. So here you are able to see it is passing on the posterior compartment and behind the medial epicondyle in the nervi sulci ulnaris. So that we have already seen in the nervi sulci ulnaris. Okay. So course of the ulnar nerve, which is present between the two heads of the flexor carpi ulnaris. Then it is present superficial to the flexor retinaculum in the lower part of the arm. So it passes above the flexor retinaculum, the ulnar nerve, even the ulnar artery, both the ulnar nerve and ulnar artery, they pass above the flexor retinaculum, unlike that of the medial nerve which passes deep to the flexor retinaculum. So it is seen along the medial border of the forearm. It is present between the flexor carpi ulnaris and the flexor carpi ulnaris and the medial part of flexor digitorum superficialis, and it is present anterior to the flexor digitorum profundus. So again, between the superficial and deep flexors only, it is found in the middle of the forearm. So as I said, in the lower forearm runs medial to the flexor, runs medial to the ulnar artery, but lateral to the flexor carpi ulnaris. So the flexor carpi ulnaris is the most medial structure in the forearm. As I told you, it is passing superficial to the flexor retinaculum and it is going to divide into superficial and deep branch. Okay. So actually, to concise it, ulnar nerve passes posterior to the medial epicondyle, then between the two heads of the flexor carpi ulnaris. Then it is present between the superficial and deep flexors, that is the medial side of the forearm. The lower part of the forearm, it runs medial to the ulnar artery and lateral to the flexor carpi ulnaris. Both the ulnar artery and the ulnar nerve is actually passing superficial to the flexor retinaculum, and it divides into a superficial and deep branch. So here you are able to see the flexor retinaculum passing through the carpal tunnel. This is the 4 tendons of superficialis, 4 tendons of profundus, and 1 tendon of flexor pollicis longus and the median nerve. The ulnar nerve and artery is not passing through the carpal tunnel, but it is passing above the flexor retinaculum. Okay. So branches, muscular branches in the forearm, only 1.5 muscle it is going to supply. Flexor carpi ulnaris and medial half of flexor digitorum profundus. So flexor digitorum profundus, lateral half is by medial nerve, medial half is by ulnar nerve. So that is why it is also called as the hybrid muscle. So digitorum tendons to ring and little finger. Cutaneous branches, dorsal branch or dorsal cutaneous branch gives well above the wrist and it pierces the deep fascia, and it is taking part in the cutaneous innervation of the dorsum of the hand, medial half of the dorsum of the hand, and the skin over the medial 1.5 fingers. So here you are able to see the ulnar nerve. Again you are able to see here the ulnar nerve. So flexor digitorum profundus and flexor carpi ulnaris is removed, so you are able to see that ulnar nerve here. Then it is passing superficial to the flexor retinaculum. 5 centimeters above the wrist, it is giving the dorsal cutaneous branch. So that is the dorsal cutaneous branch. That is not to be confused with this branch here, which is going to develop to superficial and deep branch. Dorsal cutaneous branch is responsible for innervation of the medial half of the skin over the dorsum of the hand. The pink colored one is ulnar nerve. So dorsum of the hand, medial half, skin, and also the skin over the medial 1.5 digits of the finger. So little finger and medial half of the ring finger. That is the cutaneous distribution by the dorsal cutaneous branch of the ulnar nerve. It also gives palmar cutaneous branch. So here you are able to see superficial branch. It gives a palmar cutaneous branch which is going to supply the skin over the hypothenar eminence. This part, palmar cutaneous branch. Again it is given near the middle of the forearm. Palmar cutaneous branch. Skin over the hypothenar eminence. And articular branches which is going to supply the elbow joint because it is crossing the elbow joint. Okay. So branches we have seen, muscular branches, then we have seen branches in the forearm is one is palmar cutaneous branch supplying the skin of the forearm, dorsal cutaneous branch supplying the skin of the medial part of the dorsum of hand, and medial one and a half fingers, skin over the medial 1.5 fingers. So applied anatomy is cubital tunnel syndrome when it is getting entrapped, when it is passing through the medial epicondyle, the nerve might get compressed. So you get a flexion and adduction of wrist, weak flexion and adduction, but some amount of flexion is there because the other flexors are supplied by the medial nerve and naturally it will provide some flexion. But you see the intrinsic muscles, the short muscles of the hand, all will be paralyzed. And you get a partial claw hand. So complete claw hand is different from partial claw hand. Partial claw hand is medial 2.5 fingers. There will be flexion at the interphalangeal joint and extension at the metacarpophalangeal joint. Wasting of hypothenar muscles, the skin over the hypothenar eminence. What is ulnar paradox? The ulnar paradox states that the more higher the lesion is involved, the less pronounced will be the claw hand. Okay, so that is ulnar paradox. Now, for example, the ulnar nerve is damaged near the wrist, more pronounced claw hand. If the ulnar nerve is actually damaged high above, somewhere in the elbow, then the claw hand will not be that much pronounced or more conspicuous. So that is the cubital tunnel syndrome when the nerve is getting entrapped here, especially what happens, the flexor carpi ulnaris muscle by two heads it arises and it sends a facial band to this medial condyle, epicondyle of the humerus. Then you again have entrapment or compression of the ulnar nerve. Okay, so that is actually called, and you are able to see the tendinous arch which is produced by the flexor carpi ulnaris muscle. So the nerve might get entrapped here. Guyon's canal, you are able to see entrapment of the ulnar nerve. So that is actually called as the Guyon's canal. Okay, so that is mainly formed by the flexor retinaculum, and above that if you see a band which is running called as the palmar carpal ligament. So between the palmar carpal ligament and the flexor retinaculum, if the nerve is getting trapped, that is actually called as the Guyon's canal. When the nerve passes through the Guyon's canal, when the nerve getting entrapment. So it is all entrapment neuropathy in the Guyon's canal, in the cubital canal or cubital tunnel, or for the median nerve, Pronator Teres syndrome. All these are entrapment neuropathies. So that is the partial claw hand and complete claw hand for you. Only if the medial two fingers are involved, namely to the ulnar nerve. Complete claw hand, if all the fingers are involved, naturally the median nerve as well as the ulnar nerve, both are involved in this one. So coming to the arteries of forearm, we are going to discuss about the origin, termination, course relations, branches, and the applied anatomy of the radial artery. So origin from the neck of the radius passes downwards and laterally. It is going to be present lateral to brachioradialis and medial to flexor carpi radialis. Then it passes to the dorsum and again come to the palmar aspect by piercing between the first and second metacarpal and anastomosis by forming the deep palmar arch along with the deep branch of ulnar artery. So you can palpate this artery at the wrist, lateral to the flexor carpi ulnaris and to the medial to the styloid process. Okay, pulsations. So peripheral arterial pulsation. So one of the arteries, the radial artery, where actually you can measure the pulse. So that you should remember mainly for the pulsations. Arterial pulsations can be actually measured in the radial artery near the wrist. So here we are able to see the radial artery. It is actually present lateral to the brachioradialis muscle and the flexor carpi radialis. Then what happens? It passes through the wrist And here it is actually the deep branch of the radial artery taking part in the formation of the deep palmar arch, which is a contribution from the deep branch of ulnar artery. I told you for a short course it passes behind, not on the palmar aspect, it passes the dorsum. Then it is going to enter into the palmar aspect or into the palm between the first and second metacarpal bones. Okay, so there it is also going to give two branches, arteria princeps pollicis and arteria radialis indicis. This is the principal artery to the thumb and this is the artery to the radial side of the index finger. That is why it is called like that. And finally, what happens is the deep branch or the radial artery itself ends by anastomosing with the deep branch of ulnar artery. Okay, so that is the radial artery for you, passing behind between the first and second metacarpal and then coming to the palmar aspect and taking part in the deep palmar arch. There, here when it is passing between the two heads of the dorsal interossea here, it gives two branches, the arteria radialis indicis and the arteria princeps pollicis. Okay. So branches of radial artery in the forearm, the first branch you are able to see anastomosis around the elbow joint, radial recurrent artery, going to anastomose with the radial collateral branch of the elbow joint. Radial recurrent artery with the radial collateral branch of elbow joint. Palmar carpal artery, it is going to anastomose with the palmar carpal branch of the ulnar and anterior and posterior interosseous artery. It will form a carpal network in front of the wrist joint. Same way it will give dorsal carpal branch. Again, this is again anastomosis at the back of the wrist joint. So the radial artery can be compressed against the styloid process. There you can also feel the radial pulse. The next is the ulnar artery. You are able to see here, this is the ulnar artery, one of the terminal branches of the brachial artery, arising at the level of neck of radius. Both the radial and ulnar artery has a common origin. Relations passing downwards and medially, and it is passing above the flexor retinaculum along with the ulnar nerve. So structures passing above the flexor retinaculum will be from medial to lateral, flexor carpi ulnaris, ulnar nerve, ulnar artery, palmar cutaneous branch of median nerve, palmaris longus tendon. These five structures: flexor carpi ulnaris, ulnar nerve, ulnar artery, palmar cutaneous branch of median nerve, and palmaris longus tendon. So in the forearm, it is related or present on top of flexor digitorum profundus, which forms the posterior relation, and on top you will have the flexor digitorum superficialis, which is actually cut for you to see the radial artery. Okay, and it is present deep to flexor carpi ulnaris in the middle of the forearm. So that is a brief course of the ulnar artery. Branches of the ulnar artery will be anterior ulnar recurrent artery, which will anastomose with the inferior ulnar collateral artery. Okay, so inferior ulnar collateral artery, anastomosis of elbow joint. Okay, anterior ulnar recurrent artery anastomosing with the inferior ulnar collateral artery. Posterior ulnar recurrent artery anastomosing with the superior ulnar collateral artery. With the superior ulnar collateral artery. So these two are again anastomosis around the elbow joint, which we are going to see again in the elbow joint. Anterior ulnar recurrent and posterior ulnar recurrent. Then you are able to see one more artery, which is the common interosseous artery, which is going to divide into anterior interosseous and posterior interosseous. So anterior interosseous running on top of the interosseous membrane. The upper border of pronator quadratus passes deep to it and then goes behind. Here in the interosseous membrane, it is going to go to the back of the wrist and anastomose with the posterior interosseous artery, forming the carpal arch. Here you are able to see that is the carpal arch, which is formed in the front, and carpal arch, which is formed behind. In the front, it is mainly formed by the palmar carpal branches of radial artery, palmar carpal branches of the ulnar artery. Then branches from anterior interosseous artery and one more branch from the palmar arch. Dorsal carpal arch again, which will be formed by the dorsal carpal branch of the radial artery, dorsal carpal branch of the ulnar artery, and contribution from anterior and posterior interosseous artery. Posterior interosseous artery is present posteriorly. Anterior interosseous artery will pierce the interosseous membrane, come to posteriorly to take part in the dorsal carpal arch. Palmar carpal arch and dorsal carpal arch are again anastomoses around the wrist joint. Posterior interosseous artery seen in the posterior compartment. Here you are able to see the posterior interosseous artery here, accompanied by the deep branch of radial nerve, whereas anterior interosseous artery accompanied by the deep branch of medial nerve, anterior interosseous nerve. It gives an interosseous recurrent artery, which will anastomose in the middle collateral and posterior ulnar and ulnar collateral branches in the region of the elbow. So I told you it forms the posterior carpal arch, ultimately the posterior ulnar recurrent artery. That is the anterior ulnar coming to the posterior aspect. Anterior ulnar, posterior ulnar and dorsal carpal branches of medial and lateral artery takes part in the formation of posterior carpal arch. So thank you very much for listening to this lecture. We will meet again in one more topic.